Welcome everybody. Today is July 23rd, 2024. This is SEVA VentRounds, and the topic today is leaks and ventilator management. Disclosures: there's no endorsement of any mode, ventilator, or manufacturer. Whatever we say, it's our opinion. It does not represent the Cleveland Clinic. I'm Eduardo Mireles, and Rob Chatburn is also on the line. We're both your hosts, and we run the SEVA VentRounds. The ground rules is this is a recorded session, so just keep your microphone muted. However, if you want to chat, unmute yourself and make a question, or put it on the chat. We can see that continuously, so it's important for us. Just we don't want background noise. There are CME if you work at Cleveland Clinic, and there are CRCE wherever you work, and if you're a respiratory therapist. Just remember to enter your name on the to verify your attendance, and then you will get credit, and you'll have to answer a little evaluation. But otherwise, that's it. So this is a classic graph that we usually focus on waveforms for pressure and volume, and flow. But the volume waveform has also a fair amount of information, and I think that there's a couple of items that we want to highlight to you. And this, the first one is, you probably have seen this. There's the baseline for volume. So this is in milliliters of air that the patient has received, and you can see here how the volume increases, actually in this case linearly, which means that the flow was constant. So this is a patient on volume control, and so you have the volume increases, and then the patient exhales, and exhalation normally is a passive event, and the volume is going to return to baseline in an exponential form, just as flow returns to baseline. So this one is the mirror image, but in reverse of the flow. And one of the tricks, and we mention this very often, is that this waveform and how you look at it is essentially an amplification of the flow waveform. So sometimes when you cannot see things on the flow waveform, come and look at the volume waveform. That's one of the tricks. The second item that you need to be aware is that the ventilator does a little trick, and I presume this is constant, at least for the majority of ventilators that we use. I don't know of a ventilator that doesn't, but I'm sure that there must be one that does not do this. But in general, when they start delivering the inspiratory volume, it starts from 0, okay, and then it reaches the inspiratory volume, and then the patient exhales, and it measures how much is coming out. And then if the next breath is started, so if another mechanical breath is started, then it will reset the volume to 0. So you'll see this step decrease, like you see over here with the red arrow. You'll see a drop, a sudden drop in the volume, but that's because the machine is resetting to 0, and then you see it again go up. And so this discrepancy between the inhaled and exhaled creates this little step. And we've called it the square root sign, and it has multiple causes. One is that you didn't exhale enough, and the other one is a leak. I'm going to pause there and ask Professor Robert Chatburn to tell us what do you think? Any other comments, Rob?
Yeah, in volume, can you hear me?
Yep, perfectly.
Okay, so in volume control, the patient is constrained to inhale whatever tidal volume you have set at whatever flow rate you have set. But for any mode of ventilation, exhalation is always pressure controlled, which means that the patient can exhale whatever they want. It could be the same, it could be more, it can be less. As you can see in this diagram, the patient did one, exactly the same exhale as inhale, and 2 that were less. And you can actually see the volume curve go below 0 if they exhaled more than they inhaled, depending on the way the display works for the ventilator. But that's why you see those things.
Yeah, and actually that's a great point, and I'm thinking about how to make this graph better. And perhaps the better graph would also see, because we see that sometimes is that the tidal volume goes below the baseline and it disappears. And that just demonstrating that the patient is exhaling, activated the expiratory muscles, or perhaps had air trapped from the prior. Especially this happens often when they get double trigger or two breaths in a row. So now the patient has two breaths inside, but the thing reset. And as it resets, boom, then you exhale double the amount. So really just be aware of these little details. It says PC due to PEEP, pressure control due to PEEP or pressure feedback sensor. I presume that he is referring why the pressure is controlled during exhalation, and that's because you set the PEEP. And when you set the PEEP, you're controlling pressure. So the machine is going to try to keep the PEEP at that value. Is that correct, Rob?
That's correct.
Very good. All righty. So now that you have this key piece of knowledge, I'm going to show you an image, but remember, as we show you the image, you're going to try to run to the volume curve, but no, we go first to the tag, okay? And again, we're not hiding anything, so we start by the tag. So what's the tag for this mode? And by the way, this is an image that Ariel had in the last 24 hours in one of our patients. So this is fresh out. This is not a simulator. This is the real deal. So what is the tag? So you can put it on the chat. And remember, you can use your ventilator mode map app, or you can use the card, or if you have memorized it. Actually, at the end, you're going to end up using this ventilator so much that you will master this ventilator. Excellent. So this is, absolutely pressure control, CMB, S. And we know that there are several clues here for that. If the first one, the key one, is the pressure is constant during inspiration. And as we have said, ventilators are not very good at controlling pressure, but in this case, it's beautiful. It looks like a perfect square waveform. Actually, it's kind of book-like image, I would say. But the flow doesn't look geometric. Actually, it has a little bit of descending, and the tidal volume is probably about the same. So those don't help you, but this is the pressure is being controlled. And the I time is exactly the same between the both of them. One of them is triggered by the patient or by a signal that the ventilator interprets as the patient. The other one is triggered by the machine. You see that because the color has not changed in here. That's a nifty trick. Majority of ventilators now will tell you that. The books in general try to guide you that you should look for a drop in pressure when it's a patient trigger, or that the flow should cross over the baseline. And those are good markers of patient activity, but not necessarily present all the time. So don't trust, the ventilator can tell you if it was the ventilator or the machine. And set point, because we essentially, the person that set this ventilator, you can see here, the operator set the inspiratory time as well as the pressure above PEEP that the patient is receiving. Rob, anything on the tag?
Just to say that there's no tidal volume target, so you know it's not adaptive targeting at set point.
Perfect. So not volume control, not adaptive targeting either. So perfect. So what is the load? So here, remember, we read what's the load during inspiration as well as what's the load during expiration. So let's start by inspiration. What do you think is the load? Elastic, resistive, or PMOS? Second for you guys to enter. Ariel. All right, so I see a couple of people putting in. So let's go and read these together. So we see, yes, a trigger here, but I always remember if you're controlling the pressure, your eyes will go and look. You're always going to go and take a look at the flow waveform. So as you see the waveform, it's going to be a little bit tricky in this case, but remember that what you're looking is an exponential decay of the flow, just like perhaps this one. I mean, you see that how it goes down, and and I'm going to make it bigger for a second so that you can take a look. But you can perhaps see a little bit of that exponential decay, but it really takes a long time. I mean, the inspiratory time that Ariel had placed on this patient was around 0.8, almost a second, and it didn't reach the baseline. So this is a pattern that it's demonstrating. If you would follow the time constant for this is very prolonged. I mean, I'm just drawing here, but it's very long, and we see this in patients with very high resistive load, very high resistive load. This could also be that the patient is doing effort. So I could see how you're looking at this and saying, well, it's not decaying like this. So all of this may be that the patient is doing effort, and it could be. It certainly could be. Although there are some things that tell you that this is not as much effort, which is the pressure did not have any change, neither here nor here. And then Ariel put, well, the patient had just been intubated. So this changes a little bit the pattern for all of us to read on. But it's important for you to recognize that drop is going very slow. So this is highly, and you see how both of them are identical. And in this one, there's no patient trigger. So if both of them are identical, it makes me think more about our resistive load. Rob?
Yeah, and I will comment later on because I have another observation, but it's not time yet.
All righty, very good. So I would say that, but you agree that this is on the resistive pattern, correct?
It's more complicated than that.
Well, go ahead and say it. But I don't like surprises.
Well, the next step is to look at the inspiratory flow versus the expiratory flow, right?
Yes. But right now, if you looked at the inspiratory flow, do you see any evidence of PMOS?
No, but if you're restricting yourself just to that, you'd have to say it's a super high resistance, almost an unbelievably high resistance.
Yes, exactly.
If that's what you want to say, I agree with that.
Yes.
But we're going to have to modify that.
Well, we'll see. So let's take a look now at the expiratory load, right? So the expiratory load, what we heard is, well, Ben Buster said, well, this looks like elastic. There's a bunch of elastic loads. And so, and that is because it returns to baseline. Actually, if you pay a little bit of attention, you see that the flow crosses above the baseline, right? And I think that's where Rob is trying to get us. But let's think about this for a second. So you have a very high, it returns to baseline relatively fast, right? And this is one of the teaching points that sometimes we forget. And Rob, you want to comment about what I'm shading right now?
Yes. From the theory, we know that the area under the flow time curve, the area is equal to the volume. So the area under the inspiratory flow curve is the inhaled volume, and the area under the exhaled flow curve, the X hash marks there, is the exhaled volume. And in a closed system, those areas have to be the same because the volume in has to be the same as the volume out, unless there's PMOS or something like that. But for a passive closed system, those two areas have to be the same. They won't be the same shape, of course, but they'll be the same area.
Excellent. In this case, they are not, right?
Not by a long shot.
By a long shot. And actually, we can definitely see up here how the volume increases then it exhales, and actually this amplifies it, and you can easily see how it reaches essentially flatness, and then it resets, boom, and it repeats again. So this speaks that this patient has a very large leak, right? So this is, so you can see a massive square root sign, and then you can see the discrepancy between inspiratory flow and expiratory flow. So now, Rob, I would like you to comment a little bit. I think that this is the part where you're going, is if you look at the expiratory and the inspiratory, why are these different? I mean, we know that there's no PMOS here. So why is this different, and where were you going here?
Well, where I was going is that you have established that you have a massive leak, right? And the leak exists on inspiration and expiration, but as you can see, because of the leak during inspiration, the exhaled volume is much less than what was put out by the ventilator. Okay, so the volume that comes out is the volume that was essentially delivered to the alveolar spaces. The volume that went in, some of it went to the alveoli and some of it went out a leak. So if you were to model this with an electrical analog, what you would see is a resistor and a capacitor in series or in parallel with a big resistor, right? So the resistor and the capacitor, or the compliance, represents the airways resistance and the compliance of the lungs. And the big resistor that's in parallel with that is the leak out to atmosphere. So essentially what's happening is you have a leak at the, let's say at the level of the cuff. See, the cuff was deflated. So then the gas that comes, you have constant flow from the ventilator. And from the ventilator's point of view, it's doing volume control. But that most of that flow is going out that resistance. And the pressure drop across that resistance has actually turned it into pressure control as far as the lungs are concerned. If you can visualize what I'm trying to say. So in other words, that what you were trying to draw, the exponential curve on inspiration, it would never go down to zero. It would always go to some constant flow when the lungs have charged up to whatever pressure drop across that leak is. That's as far as they're going to go. And the vent will keep shooting flow out through that resistance at a constant flow rate.
Exactly. So and that's so the time constant becomes eternal because the
Infinite,
compliance of the lung is the universe, right? So
infinite time constant, right?
So essentially, you would the flow, it will reach what we call flow limitation. It would be essentially a constant flow.
Yeah, it would go down to a plateau, to an asymptote.
Yeah. So the point here is there's a very large leak during inspiration, during expiration, and you see this because it's a matter of the lungs they're open to the universe, and essentially you're going to see that. And actually, in the book for the SEVA course, the case that we present is essentially the flow looks at like a square waveform, and it's because the flow is going. I mean, it's even a larger leak than this one, but this is a very large leak. So I love that.
Eduardo.
Yes, sir.
Can we say that the inspiratory flow is recorded by the inspiratory sensor and the expiratory flow is recorded by a different sensor, which means that the difference is not coming through the vent, but it's going out somewhere else?
Yeah. Yeah, absolutely. So I mean, this is flow that is going out, right? And we're giving all that flow. Well, what I don't understand. You want to repeat the statement, Ariel? Maybe I missed the point.
The inspiratory flow records and measures the inspiratory sensor records the inspiratory flow. That's what we see higher. But the expiratory sensor on the expiratory side records a smaller volume. So we have to assume that the difference is going out through another place which is not the vent.
Yeah. It's a leak. Right? Is that?
Yeah, it's going anywhere, but it's not coming through the vent. It's not coming back to the vent.
Yeah.
It could be a leak, could be many things.
What else can it be?
No, I mean, generic, it could be a leak. I mean, the origin of the leak, it could be fistula, calf,
Yeah.
many things.
Good. All righty. All righty. So now let's look at the PV discordance. So trigger, what do you think about the trigger? Normal, early, late, false, failed. Have no fear. Good. Thank you for starting to put in your. So this is as always a tricky one, and that's why we put it. So the one that we're talking about is this one over here, right? So in this one over here, there's no patient activity. We don't see any PMOS, or at least we cannot see it. If there was, we cannot see it because of the large leak, but we don't see any depression on the flow, on the pressure, and we don't see, we don't see anything there. But I want you to pay attention to what's happening over here. So you see the baseline, right? And so remember that the device is trying to keep the system pressurized. And so it has PEEP going on to pressure flow to maintain the PEEP at the level that it can. And so you can see how the patient exhales or the system exhales. And there's a large leak. We talked about the leak. You see how it crosses over the baseline and now it's above the baseline? Flow above the baseline means that there is flow. What does flow above the baseline mean, Rob?
It means flow in the inspiratory direction coming out of the ventilator.
And
it
so
doesn't necessarily mean flow into the patient. It just means it's coming out of the ventilator.
And that is interpreted by the machine. The machine. It depends on how your trigger is set, but if you had it being on flow trigger, it would trigger.
Right. Yeah.
It can also cause, and actually you can see here how the pressure is dropping in the circuit, and then eventually it will reach a trigger threshold, which in this case was set at -2, and it will trigger a breath. So there was no patient effort. So as many of you recognize, these are what we call false triggers that were occurring because the pressure was dropping, and when it reached the threshold, boom, it would. And even though the ventilator was providing flow, it was not enough to maintain the pressure on the circuit.
Yeah, and there's no deviation of flow, which would indicate PMUS.
Right.
As long as there's no obstruction, if there's any PMUS, it'll deform the flow waveform. You didn't see that at all.
Right. So this one, it's just a false trigger, and it's caused by a large leak. And so during inspiration, we don't see any evidence. There's no evidence of PMOS. There's no evidence of PMOS, so there's no cycle. And during expiration, we cannot see anything because there's a leak and I don't see anything there. So essentially, this is a false trigger due to a very large leak. And that's a common cause of false triggers. Leaks are common. Actually, I'll invite you one day just to unplug the ventilator or to open up one of the little ports where we put sensors, and you'll see that the ventilator will go into pop, 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 pop. It will deliver several breaths in salva, one after the other, right? So I think that the question here, and Ariel brought this up, is, well, now you have this patient and that has a very large leak, that has some false triggers. So how do we manage? How do we deal with this patient? I mean, evidently, and I'll perhaps from Ariel, I will give a little bit of context, which is this patient had a large central airway obstruction for which an ET tube was placed that had to be very small, but because the patient is large, the cuff doesn't occlude the airway. if that makes sense. So you pass an ET tube through a very narrow opening, but and you're below that, you cannot pass a larger tube. So the cuff discrepancy with the trachea is huge. So you have this massive leak on this patient. So how do we deal with it? Any thoughts here?
Well, first of all, was this patient hypoventilating? Was the pH low?
That's a good question. I am not aware, but you can. The first, let's go by questions. So the first question that I would ask here is, which tidal volume do we believe? You can see here, this patient is getting 620 of tidal volume inspiration and 111 of tidal volume exhalation. And actually, the respiratory therapy is high quality, put in the height of the patient. So it's telling us that it's getting 1.5 cc's per kilo of ideal body weight. So which one do we trust, the VTI or the VTE? Have no fear. This is not an easy one. So put your thoughts. What would you trust? You're the so somebody says, can you trust any? It's good to when you ask me a question. So somebody said in between, none, neither. Rob, what are your thoughts here?
Well, if we have a leak that's a fixed orifice, like a tube with no cuff or a very small cuff, then you have to assume that the size of the leak is the same on inspiration versus expiration, right?
Yep.
And if that's true, then it will be affected by the leak, although the inspiratory volume will probably be affected more because of where the pressure source is coming from. So I think the answer is you don't know.
So essentially we're pressurizing a system, but you cannot necessarily see the tidal volume. So this reminds me a lot, like, for example, when you're ventilating somebody with high frequency oscillation, in which you can have a massive leak and you're pressurizing, but you cannot read the tidal volumes, and so you're going by chest distension and by gases and saturation, right?
Yeah, this is just like ventilating a preemie with an uncuffed tube with a high frequency jet ventilator, and there's no consideration whatsoever for tidal volumes. You do it all, like you say, by auscultation and by looking at chest drives.
Yeah. So the tidal volume in a leak this large becomes absolutely unreliable, and that's an important thing for us to recognize. And the second part I would say is in a patient like this, setting out the inspiratory time, for example, can be tricky, right? Because you're trying to pressurize a system. So there is no way to know if the patient is getting enough to pressurize the system except the physical exam, because there is no, you have to see that the chest stops expanding versus not. Any comments there, Rob?
No, I think that's exactly right. You're stuck in a situation that you are with a preemie with an uncuffed tube or maybe a big chest tube leak.
A common question that comes to us is, well, would you ventilate with volume control or pressure control? And anybody wants to choose between volume and pressure on the chat?
Pressure.
Right, let's see on the chat, I see a couple. Yeah. So let's think a little bit about this. The challenge of using volume versus pressure. Rob, do you want to talk a little bit about this? Because you do a very, he was, sorry, he's there. No, he's there. Rob, are you there?
Yeah, well, I wrote a paper on this once. I'm trying to remember what I said. I have to go back and read what I wrote. But there is a difference given the mathematical model that I was telling you about. And as I recall, that pressure control does slightly better But keep in mind that both of them are pressure control from the point of view of the lungs, because you're feeding a constant flow through a leak at the upper airway, which gives you a constant pressure. So the lungs are getting pressure control either way you do it. The question is which mode, from the ventilator's point of view, feeds the leak better. And I think it's, as I recall, it's pressure control.
Yeah,
in this
pressure
situation.
control because of, I mean, you're trying to inflate an eternal universe, right? So you're trying to inflate the balloon to a certain size, and the only way to pressurize that is by a very high amount of flow. So trying to do that with the volume seems as a very hard experiment to achieve.
Right.
Very good. So I want to highlight, this is the next image that Ariel provided. And Ariel, would you care and talking how did you dealt with the two items? The first one was the presence of the leak, and the number two, the triggering. So let's start by the triggering. What did you do to adjust this?
The triggering definitely at the beginning was flow, so I changed it to pressure trigger. Flow was definitely out false triggering a lot. Pressure trigger of -2 was still false triggering, so I had to go to -5. And the leak, I remember that was held by Alex, the RRT, and when I was very busy at the time, and he managed to mobilize the tube in the mouth, and we found a position that decreased the leak, as you can see now. I think it went from 600 to 351. We increased at least 50% of the total volume. We decreased the leak by 50%. So in this picture, I would say that triggering is in pressure at -5.
Yeah. And this is I mean, the challenge when you have an open system, and as RTs and Ariel and Rob, you can comment more, is once that you don't have a good seal on the airway, or you have a massive leak, obtaining the signal to trigger the ventilator becomes a challenge. So if this patient was awake and trying to trigger the ventilator, it probably would be very difficult to achieve that. So what other strategies could you use?
In patients that were awake, on my previous workplace, we used to use NAVA due to a massive leak, but they were triggering. This guy at this present time was still heavily sedated or still paralyzed.
Yeah. So without a doubt, I mean, when you cannot use Mike Fisher and Ariel, absolutely. So when you cannot use an airway signal, then other technologies become more efficient in this group of patients, and NAVA may be one of it, although considering there's going to be a very large leak during inspiration, expiration, no doubt. So I'm going to stop there. We passed the time, but this was great. And this is the CME for the CCF caregivers. This is the CRCE for the RTs. Please scan it and enjoy the pleasure of getting some points. As usual, send us your waveforms. There's resources. This is, I think, episode number 75 of SEVA VentRounds. So keep joining us. I see a question here about NIV with leak compensation, if that would be better. I don't know. That's a good question, and I don't know how that would interact with the patient, but probably I think that's a thoughtful statement. Very good. Thank you very much. Thank you, Ariel, for the image. Appreciate that. Have a great day, everybody. Thank you, all the new fellows, and look for you on SEVA Summit. Bye-bye.